Hi, everyone. Thank you for coming to tonight's Grand Rounds with Dr. Leiter. If anyone has any questions about the talk, please write them in the Q&A box at the bottom of your screens and we'll get to them at the end. Now, I'd just like to introduce our speaker for tonight. Dr. Leiter is Associate Clinical Professor at the Icahn School of Medicine in Mount Sinai, where she's been teaching medical students and residents for several decades. She received her medical degree from Albert Einstein College of Medicine. She completed her internship and residency at the Department of Obstetrics and Gynecology at Mount Sinai Medical Center in New York City. Dr. Leiter is president of the Park Avenue Women's Center with a very active practice of both obstetrics and gynecology. She's a national menopause clinical practitioner of the North American Menopause Society. Gila was elected president of the Medical Board of Mount Sinai Hospital, the only woman and voluntary attending to serve as president, and is a member of its Administrative Executive Committee. She was elected president of the Attending Association of Mount Sinai Hospital, representing over 3,000 doctors at the hospital and continues serving on its executive committee. Gila has received accolades from both patients and the medical community, including the Compassionate Doctor Recognition Award, Patients' Choice New York Area Award, New York Magazine Best Doctors, and Exceptional Women in Medicine. She's been featured in the Castle Connolly Best Doctors New York Metro area for the last 15 years. She serves on the medical advisory board for Sharsheret or NAVA, the pregnancy loss support group, and lectures in many community forums. And with that, take it away.
Thank you, Aderet. First of all, thank you for inviting me to speak on this very important topic. It's very common, very underdiagnosed, and very undertreated. We'll start with talking about two cases of women who have come to my office, pretty much representing at least weekly examples of urinary incontinence. So Talia is a 48-year-old mother of four. The largest baby she's delivered was 8 pounds, 10 ounces. She reports it was a tough forceps delivery. She's healthy and fit, but during the COVID pandemic gained 12 pounds and has not rejoined her gym. Recently, she developed a cough, which has lingered. And in the last few months, she's complaining of leaking of urine with coughing, with sneezing, even when she's laughing or running for the bus. And she's worried about the odor. She's worried about leakage during sex, or she is very reluctant to rejoin her gym because of this problem. Our second patient is Fran. It was a 64-year-old menopausal woman. She's been menopausal for about 6 years. She's noted vaginal dryness, and she's had a few urinary tract infections last year. She's experiencing urinary frequency, urgency. Sometimes she describes feeling the sudden urge to urinate and can't make it to the toilet without leaking. She's also getting up 2 times a night to urinate, and she's complaining that it's affecting her focus at work. So this is the beginning of just a framework for us to discuss urinary incontinence. So what is urinary incontinence? It's when a person leaks urine involuntarily or loses bladder control. It's very common. About 50% of adult women leak, although it's really a wide variability in the incidence reported. It's estimated that only 45% of women who leak at least 1 time a week or more get care. So there's a wonderful study or survey, which is called the NANS survey, which has been following people since the 60s. And in that very famous US survey, 45% of women who leak get care. So that's really a very small number. Why? Women are hesitant to seek care. It's due to embarrassment, lack of knowledge about treatment options, fear of surgery, and it really results in living with limitations, with diminished quality of life at home or at work, both in community dwelling people as well as in nursing home residents. And it affects physical, psychological, and social well-being associated with depression, with anxiety. And one really stunning number is that the 6 to 10% of nursing home admissions are attributable solely to incontinence. So Micturition or urination is very complicated. No, I'm not going to go through all of this, but we really have so many factors which are part of the micturition reflex. We have the cerebral cortex, obviously, which is the grand inhibitor of urination. The brainstem, there are two centers in the pons, which is the micturition center as well as the storage center. The bladder has stretch receptors. There's the detrusor muscle with its innervation. We have the spinal cord, S2, S3. There's voluntary, involuntary, afferent, efferent. It's really quite remarkable how complex urination is. So what are the risk factors for incontinence? Obesity is a big factor. In fact, it's more than 3 times the incidence of incontinence in obese women. Age is a factor. Multiparity is a factor, especially large babies, although cesarean section is not completely protective. Medical problems or medical comorbidities definitely is a risk factor in urinary incontinence. And what are some of those? Diabetes, with its effect on peripheral neuropathy and nerves, stroke, spinal cord disorders, genitourinary syndrome of menopause, which means thinning or lack of turgor of the tissues around the urethra after menopause. Dementia is a big factor. So cognitive impairment and dementia affect continence. Sometimes this can be called functional incontinence. Sometimes if somebody can't get to the toilet because they're unable to or unaware, that also will lead to incontinence. Chronic urinary or recurrent urinary tract infections play a role in incontinence. Even having bladder infections as a child has impact on urinary tract, has an impact on incontinence. Smoking, caffeine, alcohol use all have been associated with incontinence. Various medications play a role, such as diuretics. Constipation, chronic constipation will definitely have a role in incontinence from a variety of different mechanisms. And there's a lot of research now on the urogenital microbiome as being a factor in incontinence, especially urgency incontinence. So what are the classifications of incontinence and why do we care? Because it guides therapy. And it's one of these areas where really understanding what type of incontinence will help us guide treatment. There's stress incontinence. We'll talk about that at length. Urgency incontinence, another way of looking at this is overactive bladder. Mixed incontinence, where there's a little of both, always a little bit more difficult to treat. And then what we now call chronic urinary retention, which used to be called overflow incontinence. So what is stress incontinence? Stress incontinence is leaking urine when one laughs, coughs, sneezes without bladder contraction. And what is this due to? What is the mechanism? It's the loss of connective tissue or muscle strength to the urethra and bladder neck. And common causes are obesity, a chronic cough, trauma due to childbirth. And the other factor is the intrinsic sphincter deficiency, which also might cause stress incontinence. So there's an internal sphincter of the bladder and urethra and an external sphincter, and both of them might have deficiencies which can contribute to incontinence. What is urgency incontinence? It's the strong need to urinate all of a sudden, and the urge is so strong that you feel you cannot make it or don't make it and leak. Classic story is turning the key to the door of your home and, sudden urge and can't make it to the toilet. An overactive bladder is similar. It's urinary urgency, and it often is accompanied by waking up at night or nocturia to urinate, and frequency, and that might be associated with or without incontinence. The bladder muscle is responsible, the detrusor muscle overactivity with bladder filling. That's what causes urgency incontinence. And it's estimated that 21% of healthy, continent, community dwelling older adults may suffer from urgency. And what is overflow urinary incontinence? A little less common than either of the other two. It's continuous urinary leakage or dribbling, incomplete bladder emptying. And that's the reverse of the overactive bladder. It's actually detrusor muscle underactivity. That can be caused by peripheral neuropathy like diabetes. Could be caused by damage to the spinal detrusor nerves, such as with MS. That's why knowing a little bit about the innervation is helpful of the bladder and the urethra. A low estrogen state can cause chronic urinary retention due to lack of turgor of the periurethral tissues and to dribbling. And it also can be from bladder outlet obstruction. And what do I mean by that? You can have pelvic organ prolapse, where indeed you can't empty the bladder fully because the uterus, cervix, bladder might be extending below. It's a bulge below the hymen or outside of the hymen and obstructing the bladder and the urethra from emptying completely, and rarely from fibroids. So how do we evaluate this? And this is an area where diagnosis does not require a tremendous amount of imaging in an uncomplicated incontinence. And so understanding the types of incontinence and how to evaluate it actually is very, very, very satisfying, useful, and guides our therapy. So taking a thorough history is important. So that is assessing all urinary symptoms, perhaps doing avoiding diary, meaning recording every time you urinate, very helpful. What the frequency is. Everyone asks, what is normal frequency of urination? Less than 7 or 8 times a day. What triggers the urge to urinate, or what triggers the stress incontinence? And how many times you wake up at night, or nocturia. This will help us classify the type of incontinence. It's important to understand underlying conditions, like we talked about briefly, what medications the patient is on, what the comorbidities, what medical condition, and identifying the concept is to identify reversible causes. I'll give you an example of a very wonderful, easy, validated questionnaire. It's called the 3 Incontinence Questionnaire. And if you look at it, I don't have to really read it completely, but during the last 3 months, have you leaked urine? No, you don't have to continue the questionnaire. Yes, is during the last 3 months, did you leak urine when you were performing some physical activity, such as coughing, sneezing, lifting, or exercise, or when you had the urge or feeling that you need to empty your bladder, but couldn't get to the toilet fast enough, and then without physical activity and without a sense of urgency, which would suggest more complicated incontinence. And then during the last 3 months, did you leak urine most often by performing or doing any of the things we just recorded, we just said? And that helps us define the types of urinary incontinence based on response to question 3. So obviously, if it's most often with physical activity, then that's stress predominant incontinence. If it's most often with the urge to empty the bladder, that would be urge incontinence. Without physical activity or sense of urgency, then that might be other causes, such as what we talked about, chronic urinary retention and other neurological condition. And about equally with physical activity and sense of urgency, and it's surprising how many women have that situation, it's a mixed picture. So we are talking about evaluation. So we've done our history. We've looked at our patient, assessed their BMI, have a good idea of their underlying conditions, what medications they're on. We've done our validated questionnaire. We have a good sense of what type of incontinence, what's next. We do a urine analysis, very important to rule out either blood in the urine or a urinary tract infection, and perform a physical exam. And what are we looking for in the physical exam, other than obviously signs of dementia, cognitive impairment, neuropathy, BMI, obviously. We're really looking to see if there's any pelvic organ prolapse, as we talked about, beyond the hymen, or a vaginal bulge, simple way of saying that. We check to see if there's any urethral abnormalities. Are there any fistulas, diverticulum? Is there anything else other on our exam of the urethra and bladder? We also want to assess urethral mobility. So what does that mean? We want to see with cough, you could use a Q-tip even. We see how far down the urethra will move. If it's more than 30% from the horizontal, that's a good sign of urethral mobility and helps us guide treatment, especially surgery. And a simple bladder stress test. And what does that mean? We actually will have the patient cough when her bladder's full. Full means 150 to 300 cc's of urine, so half to full bladder. Let her cough, and then we demonstrate, is there stress incontinence? Is there leakage? If supine or lying down, it's not working, we can have the patient stand up and do the same thing. And that's a very reliable and easy and not costly test, which is very predictive of incontinence. And we want to get a sense of post-void residual urine volume, which can be done either by catheterization or even by looking on ultrasound after a patient urinates. Is the bladder still full, which would suggest chronic urinary retention and the things we mentioned. And the main thing in our evaluation, what is the impact on quality of life? How much is the patient made uncomfortable by the situation? Is this affecting quality of life, both psychological, physical? Is it causing social isolation? Is it, affecting patients' well-being? So what is the treatment of urinary incontinence in females? So we've gone to the classic 6 points of evaluation that we talked about, which was the history, physical. We've talked about the assessment of bladder stress test, urethral mobility. So how do we treat urinary incontinence? So first thing, lifestyle modification. And what do I mean by that? Weight loss, which is amazing. It may decrease incontinence episodes by 70% in women who are overweight. So that's really quite a large number. Dietary changes, cutting down alcohol, caffeine, and modifying fluid intake. So you don't want to be drinking more than 64 ounces is one estimate, and maybe drinking small amounts earlier in the day rather than large amounts right before bedtime. Treating constipation, very important, really helps with urgency incontinence, smoking cessation. Now, pelvic floor muscle exercise. So this is an area which has truly blossomed over the last decade or so. Every good physical therapy unit will have a pelvic floor therapist, and it's an extremely useful set of exercises, which helps strengthen pelvic muscles. Biofeedback is very helpful. I use a lot a system which is a vaginal probe with a sensor which a patient can record what the muscle strength that she is doing her Kegels or pelvic floor muscle exercises onto a smartphone, and gets feedback from her achievements of twice a day. But biofeedback can be very helpful, and bladder training to regain bladder control. So mind over bladder, what does that mean? One technique is to actually record what the voiding frequency is each day, how many hours in between voids, and try each day to lengthen the time between voids to strengthen the bladder muscle. Very useful technique, especially with urgency incontinence. What else is helpful in treatment? Topical estrogen. So there are about 100 different topical estrogens. creams, suppositories, rings. There's even oral medication, which I don't particularly use because it increases the risk of blood clots, but there is a whole array of safe and effective topical estrogens for women who have thinning of the periurethral tissues, or what we call now genital urinary syndrome of menopause. And it doesn't have to be just with menopause. Some women who are breastfeeding long periods of time will have thinning of the periurethral tissues, and indeed might have some urgency incontinence and might benefit from topical estrogens. Pessaries have some limitation in their use. They are used for pelvic organ prolapse, but can be used as continence for people who cannot do other things. I'll give you, here's a nice picture of an array of pessaries, pretty frightening looking things, but they can be fitted and can help with continence in certain cases. If conservative measures fail, or if a patient really wants rapid relief of her stress incontinence symptoms, then mid-urethral slings are used. I have a picture here. Till the 90s, surgery for stress incontinence or for helping with urethral support was done either with an open procedure or laparoscopic procedure, where the bladder neck was tacked up to Cooper's ligament, and that had a lot of side effects and adverse complication. Now, mid-urethral slings have been done since the 90s, and there are several types. Retropubic slings, and that's where small incisions are made in the vagina and pulled out through small incisions in the pubic area. And then there's also transobturator slings, which you can see, which are pulled out through the groin. Retropubic slings are a little more effective, but tend to have more serious complications, and the transobturator slings. And both of these procedures, and there are many different types of them, but this is the two main types. Both of these are small polypropylene mesh, mesh, and they are quickly will incorporate native tissue, and the erosion, which a lot of women have heard about and are afraid of, the rate is very rare. It is only 1.7% is what's estimated, and is mesh has gotten bad press because of its use in large areas of mesh for pelvic organ prolapse, where it's now no longer approved for use by the FDA. So mid-urethral slings are small bits of mesh that are very effective in treating stress incontinence. And again, this is not something that you would start. For most women, you would start with conservative measures, and if that fails, move on to surgical methods. There are also, there are other techniques such as urethral bulking agents, where beads or calcium can be injected into the periurethral tissues, less effective than surgery, but sometimes used if surgery fails. For urgency incontinence after physical therapy and behavioral therapy, like bladder training, there's a host of medications that can be used to relax the bladder. So this is for urgency or overactive bladder. There's medications that are antimuscarinic medications, and they have quite a bit of adverse side effects, such as dry mouth and constipation, which in and of itself can further worsen urgency. And in fact, recently has been shown to be associated with an increase in dementia. There's a newer drug, which is a beta agonist, which is called Myrbetriq, and it causes muscle relaxation with much less side effects and with no known association with increasing cognitive dysfunction. And what else? So there are new horizons or new things that are being used, such as Botox injections, of course, into the detrusor muscle, and that's been shown to be effective. But mostly for overactive bladder. Sacral neuromodulation is being used, which stimulates the nerves with electrode placement. And there was a study that came out last year of how gentle yoga may decrease inflammatory markers such as TNF and may help relieve inflammation and symptoms associated with mostly overactive bladder, but with urgency incontinence. That's certainly something to try. It'll be useful on many, many, many arenas. So what are our take-home messages? One is to seek treatment for incontinence of bothersome. And so that's true for all of us as well as for our patients. Ask your patient, especially if it's a woman who's postmenopausal or has had many children, are you leaking? It's amazing the answers you will get if you ask the question. When is it important to seek help? When are we worried about a complicated situation? And in fact, we divide, incontinence, uncomplicated and complicated. So when are there signs that we need to do more immediate or further investigation? If there's sudden incontinence, if it happened rapidly, weakness, abdominal pain, or blood in the urine. So those are areas that, if that occurs, seek help, meaning, do further investigation. It's a more complicated situation. And obviously it's helpful to understand the type of incontinence, what are contributing factors, what could we modify, and what treatment is best in the situation. So let's go back to our lovely two patients. Now that we have this, what my daughter called a stream of information. Adara didn't want to name it that, but I got it in, Adara. So Talia is suffering from what seems to be urinary stress incontinence. She has some risk factors. She's gained weight. She's had big babies, maybe a tough delivery, which might have disrupted some of her periurethral tissues or levator muscles. Her cough is contributing. And we really would like to examine her, see if there's any pelvic organ prolapse, see what her periurethral tissues look like, and see how this seems to be affecting her quality of life, and see how we can treat her. We will probably start with recommending pelvic floor PT. If she can't get to a physical therapist, perhaps offer her one of these home vaginal probes, or maybe ask her to do some yoga at home. And if she's in a real rush to take care of the problem, maybe recommend doing a midurethral sling if she fails other methods. And again, how it's affecting her quality of life is going to guide us in terms of her treatment course. With Fran, who's the menopausal woman, we'll examine her and see what degree of atrophy or thinning of the periurethral tissues there is. Recommend if she's a candidate, and almost everyone is a candidate for topical estrogens, except for women on aromatase inhibitors for breast cancer. So that particular group of women, we don't use topical estrogens, but everyone else, there's very, very, very little systemic absorption. And so we can offer her vaginal creams or suppositories and see if that helps her. We'll examine her urine because we want to make sure she doesn't have a chronic urinary tract infection. We'll also check her urethra, make sure there's no diverticulum or some reason that she's having UTIs and incontinence. And if any of those are present, we'll treat that. We would ask her to do avoiding diary, and we would ask her to think about bladder training and give her a little program, how to extend the times or the intervals between voids to see if we can get to a better situation. If none of this is helping, we might offer her some medication, probably starting, as I said, I much favor the beta agonist, which has less adverse side effects. And again, her quality of life being affected is what is going to guide our therapeutics. And that's it. I'm so happy to answer any questions. Darren, are you going to take it away, or do you want me to check the chat?
Or I can read them from the Q&A box.
Sounds good.
The first one is, we have an attendee who says, I'm post-menopause with urge incontinence and sometimes leakage when I don't feel the need to empty bladder. What can be done to help?
So we would want to know if in fact there is thinning of the periurethral tissues like we talked about. Also, whether indeed there's any chronic urinary retention. Both of those could be helped with some topical estrogens. And so certainly if indeed there is thinning and you're a candidate, I would suggest trying some topical estrogens and seeing if that's helpful. Doing a voiding diary, seeing what the triggers are and how to do that. And pelvic floor PT helps with urgency incontinence as well. So that might be something to think about as well.
Okay, and secondly, we have another attendee who wrote, I'm 68 years old with frequent waking to urinate at night. What can I do to reduce frequency and sleep better?
So one thing that I would do is just try to reduce some of your fluid intakes late at night. Also, if you're a big caffeine or alcohol drinker, try to limit that. I would also recommend making sure that the urinalysis is normal. The other thing that I would do is consider taking medications if you're a candidate, and the medications can be very useful.
Okay, and our third question, I exercise daily and have leakage when I jump. Are there things I can do at home without PT to prevent leakage?
Yeah, so as I was saying before, one is doing Kegels, which, you can look up what we talk about, which is 10 muscle contractions for 10 seconds, 3 times a day. That's one thing you can do on your own. There are systems where you can use a sensor, hooked up to a phone, which is a wonderful biofeedback, and seeing how good your Kegels are, right? How effective they are. And making sure that your bladder is empty before you exercise is very helpful. And so doing the exercises and doing your Kegels and doing that at home can be extremely effective. I would suggest also that someone examine you and make sure that there's no obvious pelvic organ prolapse that could be helped. I don't know why the visuals for Javi is not working out. So sorry, Adara.
Yeah. Okay, that's it for the questions. So thank you so much for speaking tonight. I learned a lot from your talk, and I think this is a very important topic. So I'm really glad you were able to come on tonight.
Yay.
And thank you to everyone for joining us tonight, and have a good night, everyone.
All righty. Have a good night. Thank you.